Good morning, everyone. My topic for today's session is localization pearls in patients with painful ophthalmoplegia. So, this is the beginning of efferent pathway. So, just a minute. So, painful ophthalmoplegia, as in any ophthalmoplegia, is involvement of the ocular motor nerves. Third, fourth, or sixth, or in varying combination, all of the three or two of the three. And sometimes we can get sensory division of fifth nerve along with ocular motor nerves, as well as second involvement, the optic nerve involvement. In painful ophthalmoplegia, the additional thing is pain, which can be hemicranial, holocranial, retroorbital, or periorbital. So, how should we localize the lesion in the patients of painful ophthalmoplegia? We are going to learn that in the next 25 to 30 minutes. So before going to the localization, to the neuroanatomy of ophthalmoplegia, let's begin with some cases. So the case one is a 35-year-old lady who presented with multiple cranial nerve palsies. She had right third, fourth, sixth, the ophthalmic as well as maxillary division of the trigeminal nerve, and she had normal vision. The point here to note is that she had normal vision. Another patient who is also a 35-year-old lady who presented with low-grade fever, headache for 3 months, but she presented to us that she was unable to open her eyes for the last 1 month. When we examined her, she had bilateral third palsy with involvement of the pupil. Both the pupils were dilated. The third case is a 55-year-old lady, a middle-aged female with history of type 2 diabetes mellitus, who presented with acute onset right-sided third cranial nerve involvement with preceding headache. And the pupils were normal in this patient. Another patient of the same scenario who came on teleconsultation, and her only complaint was that she said, "Meri putli phail gayi hai." She complained of dilatation of right side pupil. On further inquiry, she also complained that she had onset with headache, and the headache lasted for around 1 to 2 hours, and within 30 minutes of having headache, she had dilatation of pupil, and the pupillary dilatation persisted for 7 days. She did not have any other involvement of right third except for pupillary involvement. So where is the lesion in all these cases? So how should we localize the lesion in all these patients? So to know how to localize the lesion, we should know from where these nerves arise, how they travel along the brainstem and the subarachnoid space, and how they go on to supply their target muscles. So we'll revise one by one each and every nerve. So first nerve is third cranial nerve. So this is the picture depicting the third cranial nerve nuclei. The third cranial nerve nuclei, they reside in the midbrain at the level of superior colliculus, and they are adjacent to the periaqueductal gray matter. If you look at this figure, the nuclei are arranged in a rostrocaudal fashion, and there are paired nuclei as well as there are two single unpaired nuclei. The first is Edinger-Westphal nucleus, which supplies the parasympathetic pupillary supply, and the second one is central caudal nucleus, which is the single most supply for bilateral levator palpebral superior. So the point here to notice that if there is a nuclear lesion, there will be bilateral ptosis and bilateral pupillary involvement. The second point to note here is that when the axons arises from superior rectus nucleus, they cross immediately to the opposite side and go on to supply the opposite superior rectus muscle. So if there is a lesion here, because the decussation is happening at the level of the nuclei, if there's a lesion here, it will lead on to damage to the restriction of both the superior rectus and not only on one side. So if there's a nuclear lesion, there will be bilateral ptosis and bilateral upgaze restriction, never unilateral. The third point to note here is that the medial rectus nuclei, you can see the medial rectus nuclei are scattered. They are not at a one place like superior rectus or inferior oblique nuclei. So whenever there is a nuclear lesion, there has to be involvement of medial rectus along with other nuclei also. And if the patient is presenting with sole medial rectus restriction, the lesion can never be nuclear. I hope everybody understands that. Moving further, when the axons arises from oculomotor nuclei, they travel along the path, along the fascicular portion, and they cross red nucleus, substantia nigra, and crus cerebri. So whenever there's a fascicular lesion, whenever there's an infarction or demyelination or tumorous process going on and involve the fascicular portion of oculomotor nerve in the midbrain, there can never be sole involvement of oculomotor nerve, and there has to be some long tract signs in the form of spasticity, exaggerated reflexes, or hemiparesis, or movement disorder, or Parkinsonism, or ataxia. The second point to note here is that the lesions, if the lesion is in the fascicular portion of the oculomotor nerve, it can spare the pupil, because even in the fascicular portion, the arrangement is like this. This is the medial most part and this is the lateral most part, and pupillary fiber are the medial most part. So if the lesion is involved in this part of the fascicular portion, the lesion will not involve the pupil. So if the patient is having pupillary sparing oculomotor nerve palsy, it does not mean that it has ruled out fascicular portion. So the nerve has crossed the midbrain, and now it exits from the midbrain from the anterior aspect at the medial portion of the cerebral peduncle, and as it grows anteriorly, it goes through between the posterior cerebral artery and superior cerebellar artery, and then it runs parallel to the posterior communicating artery. So here the nerve is can get damaged by the subarachnoid space disease processes, meningeal processes, or because of these vessels, the nerve can get damaged because of the aneurysmal process. The most common aneurysm which we see is arising from the posterior communicating artery aneurysm. The most important point here is that whenever there is aneurysmal third cranial nerve involvement, there is always involvement of the pupil. Why? Because the pupillary fibers are superficially placed, and because when the compression occurs from here, the pupillary fibers are first to grow. That's why you will almost always a dilated pupil in an aneurysmal third cranial nerve palsy. What happens in diabetic ischemic third nerve involvement? The vasa nervosum affects first the deepest layer of the nerve. So the deepest fiber go first, and thereby the superficial pupillary fibers are spared in an aneurysmal, in an ischemic third cranial nerve palsy. So this point is important here. The nerve goes further and it crosses medial to the uncus of the temporal lobe and the edge of the tentorium. So it is susceptible to the processes which lead on to increased raised ICP, because if there is uncal herniation, the nerve gets damaged here, and this is a very important ominous sign, and it's an indication for surgery, to go for surgery if you find ipsilateral enlargement of pupil, and this pupil is also called as Hutchinson pupil. The nerve travels anteriorly, pierces the dura, and enters the cavernous sinus just above the entry of the trochlear nerve, and further it passes through the cavernous sinus into the superior orbital fissure. Just before the entry into the superior orbital fissure, the nerve divides into superior division and inferior division. The superior division goes on to supply levator palpebris superioris and superior rectus, and inferior division supplies inferior oblique, inferior rectus, medial rectus, and pupillary fiber. This division is important because if the patient is presenting only with ptosis and upgaze restriction, the lesion is likely after the division of the nerve. So now the fourth cranial nerve, the trochlear nucleus lies caudally to the third nucleus in the lower portion of the midbrain at the level of inferior colliculus. And as you can see, there are a lot of nearby structure which are present, like MLF, decussation of superior cerebellar peduncle, uh, mesencephalic nucleus of trigeminal nerve. There's also descending sympathetic fibers here, which can get damaged. So the nerve arises from the nucleus, it goes posteriorly. It is not going anteriorly, it goes posteriorly and decussate in the anterior medullary velum and arises from the dorsal aspect of the brainstem. So this is the only nerve only cranial nerve which arises from the dorsal aspect of the brainstem. So if there is any lesion over here, there will be contralateral superior oblique palsy, and if there is any lesion here, there will be bilateral superior oblique involvement, and if there is a lesion distal to this part, there will be ipsilateral superior oblique palsy. So the nerve exits from the posterior apex, it travels in the quadrigeminal system, ambient system, crural system to reach the pontomesencephalic system, and there the nerve travels in between the posterior cerebral artery and the superior cerebral artery, travels anteriorly um, uh, uh, through the medial to the petrous rays and pierces the dura just below the third cranial nerve into the cavernous sinus. So the lesions here can lead on to contralateral superior oblique palsy with various syndromes like contralateral superior oblique palsy with ipsilateral INO because of involvement of MLF, or ipsilateral dysmetria or ipsilateral Horner's because of involvement of descending sympathetic tracts. Moving on to sixth cranial nerve. The sixth cranial nerve nucleus lies under the floor of the fourth ventricle in the lower part of the pons, and it lies in close contact with the seventh nerve, with facial nerve, because the genu of the facial nerve lies just above the abducens nucleus and forms the facial colliculum. So whenever we have nuclear lesions of sixth nerve, it is usually accompanied with the lesions of seventh nerve also. The second point to note here is that the abducens nucleus, it contains lateral rectus motor neurons which supplies lateral rectus, ipsilateral lateral rectus, and it also contains the interneurons which crosses the midlines and forms the MLF and goes on to till oculomotor nucleus in the midbrain. So whenever lesion occurring here, it will not lead on to only ipsilateral lateral rectus palsy, it will also cause ipsilateral gaze palsy. And practically the patient never complains of diplopia because it's a ipsilateral gaze palsy. The axons arises from the nucleus and it passes anteriorly. During their course in the fascicular portion, it crosses medial lemniscus and corticospinal bundles, leading on to various syndromes. If the lesion occurring near the nucleus, it will cause ipsilateral gaze palsy because of nuclear involvement, as well as ipsilateral seventh nerve involvement with dysmetria, which is known as Fauvelet syndrome, and Millard-Gubler syndrome is because of involvement of fascicular portion of the nerve, along with seventh nerve involvement with contralateral hemiparesis because of involvement of corticospinal tracts. The nerve exits the brainstem at pontomedullary junction and enters the subarachnoid space, and thereby it takes a sharp turns upside and travels alongside the basilar artery and the clivus. This course is important because it's a long course which the nerve is taking. It is ascending the brainstem, as well as the clival disease process, the base of skull disease process can affect the nerve in this region. Also, the second point to note here is that the nerve lies in contact with 12th nerve here. So the lesions which affect, if the patient has involvement of 6th and 12th, the only localization which is possible is the lesion affecting near the clivus, and usually a nasopharyngeal carcinoma or any other infiltrative process presents because of lesion here. The nerve ascends further and it enters the Doral's canal, just entering below the petroclinoid ligament, And this point is important as it's near the petrous ridge. It's near the petrous ridge. So if there is inner ear pathology, middle ear pathology, the nerve can get affected, and the syndrome is known as Grady-Negro syndrome. The patient will present with sixth nerve involvement, eighth nerve involvement, as well as ipsilateral periorbital pain. Sometimes they can have seventh nerve involvement. Also, the another point here is that in the Doralose canal, the nerve is little bit tethered inside the Doralose canal. It is not free. So if there is rise in intracranial pressure, the nerve does not have space to move on, and that's why it gets stressed there, and thus present with false localizing sign of sixth nerve involvement, which we usually see in patients with hydrocephalus secondary to tubercular meningitis or cryptococcus meningitis, or in cases with IH. Further, the nerves enter the cavernous sinus, the substance of cavernous sinus, and it lies in close contact with internal carotid artery. So the nerve is more close to the internal carotid artery as compared to third nerve, fourth nerve, or sensory component of trigeminal. So any process which starts from internal carotid artery will involve first sixth nerve and then these nerves. Another point is that if the process starts from here, the patient usually has painless ophthalmoplegia. If the process starts laterally from the cavernous sinus, the patient usually have painful ophthalmoplegia because of involvement of trigeminal nerve. Second thing to note is that the nerve, during its course through the cavernous sinus, the nerve has, for some distance, it is accompanied by sympathetic fibers. So the lesion over here in the cavernous sinus can be associated with ipsilateral sixth nerve involvement with ipsilateral Horner syndrome. And the syndrome is known as Parkinson's syndrome. The nerve goes further, and in the cavernous sinus, in the lateral wall, third, fourth, and sensory component lies, and sixth in the substance, and there is internal carotid artery. Cavernous sinus syndromes are divided into three parts on the basis of exit of the sensory divisions of the trigeminal nerve. You can see in this diagram that mandibular division is first to go, then the maxillary, and ophthalmic division along with other ocular nerves, they enter the superior orbital fissure and then the orbital apex. So if a lesion involves the posterior cavernous sinus, it will involve all the three divisions. And if the lesion is involving anterior cavernous sinus, it will involve only the ophthalmic division. In the superior orbital fissure, after the superior orbital fissure, the nerves enters the orbital apex, and the only difference the only prominent difference between cavernous sinus lesion, superior orbital fissure, and orbital apex lesion is that there is involvement. If there is vision loss, there is involvement of second nerve, then the lesion has to be in the orbital apex. This is the main specific difference between superior orbital fissure lesion and orbital apex lesion. Also, when the lesion is in orbital apex, it will lead on to chemosis, proptosis, and congestion of the eyes. Further, if there is involvement of isolated muscle, there can be painful ophthalmoplegia along with congestion of the eyes, proptosis of the eyes. So if you are not finding lesion anywhere, there is isolated muscle weakness, there is pain on the movement of the eye, lesion can be in extraocular muscle. So coming on to our cases, the first case is a classic case. We are seeing many cases of mucormycosis these days. So the patient's presents with multiple cranial nerve palsy. This patient has right third, fourth, sixth, and sensory division of trigeminal involvement, and thus the lesion has to be where all the nerves are meeting together. So the lesion can be in cavernous sinus, can be in superior orbital or orbital apex. The orbital apex is out because the patient did not have any vision loss. The vision is normal. There is involvement of both ophthalmic as well as maxillary division. The lesion is likely in the middle part of the cavernous sinus. So when we did MRI, there was a lesion in the cavernous sinus. The next case, who presented with inability to open the eyes, bilateral third involvement, there is If there is bilateral third involvement and there is no sixth involvement, no fourth involvement along with that, it means the lesion has to be before the cavernous sinus, before the nerve has entered the cavernous sinus, or the lesion can be in the subarachnoid space, in the meninges, or the lesion can also be in the nucleus. But the clue here is that the patient has headache, the patient has pain. It means that the patient has involvement of some painful structure of the scalp. So most likely the lesion was involving the meninges or the subarachnoid space. And when we did MRI, there was extensive exudates involving the oculomotor nerves, involving the third nerve. The third case, 50 middle-aged female with type 2 diabetes mellitus, with acute onset ptosis, with history of headaches. So when we see this kind of patient, because there is pure oculomotor involvement. So pure oculomotor involvement can be anywhere along the course, but more likely after the exit from the brainstem and before entry into the cavernous sinus. So most likely the lesion is between the subarachnoid space and before the entry into the cavernous sinus. So when we did the MRI was normal and CT angiography was normal. And this was the classic case of diabetic ischemic oculomotor involvement. In all these cases, whether in all the patients of painful oculomotor third cranial nerve palsy, you must go with CT angiography because an aneurysm must be ruled out. In the last patient, we had only dilated pupil, but with the history of hemicranial headache, and the patient has spontaneous resolution of pupillary dilatation that persisted only for 7 days. This is a classic case of ophthalmoplegic migraine, which usually involve a lesser age and but can start at a later age, as in our patient. So sometimes you can get only pupillary involvement in patients with third cranial nerve involvement, and MRI as well as CT angiography or MR angiography has to be done in these cases. In our patient, MRI brain, contrast enhanced MRI brain was normal as well as angio was normal. So I would like to summarize with some of an important points. If there is isolated nerve palsy, the lesion can be anywhere along the course, but usually the lesion is where the nerve is running alone, like in subarachnoid space or meninges, or along the vessels, what I told in the previous part. If there is involvement of multiple ocular nerves, like you are getting combination of third and sixth, third, fourth and sixth, third and fourth, it means the lesion has to be where all the nerves are meeting, like in cavernous sinus, superior orbital fissure, or orbital apex. If there is cranial nerve, other cranial nerve involvement along with oculomotor nerve, like you have sixth with seventh involvement or sixth with 12th involvement, the lesion has to be at the skull base or subarachnoid space where all the nerves can get damaged because of sharing of the same space, or in the diffuse meningeal process, which is affecting all the nerves. If there are long tract signs in the form of exaggerated reflexes or hemiparesis or cerebellar involvement or movement disorder, the lesion is more likely to be in the brainstem. If there is optic nerve involvement along with third, fourth, sixth, then the lesion has to be near the orbit or orbital apex. If there is facial sensory loss, trigeminal sensory involvement, the lesion has to be in cavernous sinus or superior orbital fissure. If there is proptosis, chemosis, congestion of the eye, the lesion is likely in the superior orbital fissure or orbital apex. And last but not the least, if there is bilateral ophthalmoplegia, you are not getting any cause, pupil is spared, always rule out a neuromuscular junction disorder.